Great, excellent. Well, thank you indeed, Ab, Francesco, and Bill. Thank you very much indeed for inviting me to start off this session ahead of some amazing colleagues who've made such a difference to this subject already. So I think to kick straight off, whatever your views on fetal surgery in myelomeningocele, I think it's difficult to deny that this hasn't been a great success of translational research. It began as an animal model that was then trialed in humans through a randomized controlled trial, and then brought into clinics now in many places around the world. And I think particularly importantly, and as we demonstrated, I think by a number of my colleagues speaking today, there's still a very strong audit, basic science going on to maintain this cycle of translational research, which I think is to the benefit of neurosurgery. So I think in the moments I've got to speak to you, I was going to sort of do, I suppose, a little bit of a critique on where I see things at the moment. Have the MOMS results been sustained, replicated over time? Well, what is the current status? What's the neurosurgical perspective on the open versus the fetoscopic debate? And I know this is going to be, Frank's going to be talking very specifically to this shortly, so I'm not going to spend much time on that. What are the implications for postnatal neurosurgical practice, and where do we see this going in the future? As you all know, the headline results of the MOMS trial were basically that shunting requirement was reduced and motor outcomes at 30 months also appeared to be better. But actually, have the neurodevelopmental outcomes, have they been sustained over time? And as a means partly of trying to answer this question, last year our group published this systematic review and meta-analysis with quite strict criteria. And in fact, whilst having screened large numbers of studies, there were two that met the strict criteria. It covers 213 children assessed at 14 to 53 months. So how have things panned out in terms of hydrocephalus? Well, I think as you'll see, the requirement for a shunt at 12 months has been sustained over time. The number needed to treat, 1 to 2. So for every 2 babies treated prenatally, 1 fewer requiring a shunt. But I think it's important to look behind these statistics. Size matters at the time of surgery. Those advantages in terms of reducing shunt rate are better when the ventricles are small at the time of surgery. They are less good when the ventricles are big at the time of surgery. I think the other thing is that timing also matters. This is data based on some work by Fabio Peralta in Sao Paulo, who's mathematically modeled over a large number of cases the likelihood of having to place a shunt. And as you can see, each of these lines represents increasing ventricular size at the time of surgery. And as I've just said, the bigger the ventricles, the more likely will be a shunt. But also timing is important. The earlier the shunt, the prenatal repair is done, the less likely a shunt will be required. The shaded area here is a projection, but I think just to show that people who are pushing surgery later, and I think in an attempt to reduce prematurity, some people are doing that, but clearly they are losing the advantage in terms of shunt placement. And also, what of pathophysiology? Are we actually changing the nature of hydrocephalus through prenatal surgery? Samer, who's going to be speaking to us shortly, has shown very good results from his ETV and his prenatal children. And it may be that prenatal surgery is changing the balance between the obstructive and the communicating components of hydrocephalus in this population. What about the hindbrain herniation? Again, when one looks at this systematic review in subsequent and large studies, one can see that again, there does appear to be a clear advantage to prenatal repair in improving the radiological features of hindbrain herniation. Number needed to treat 1 to 4. You can see, here's an example. This was a prenatal case. Here's the MR of the child only 72 hours after surgery. This is one of the early cases I was involved in and was quite stunned to see the immediacy of those changes. But I think it's important to realize we in the neurosurgical community are well aware that the Chiari-2 malformation is a much wider and more complex anomaly. It's more than just herniation of the tonsils. In fact, there's a whole panoply of abnormalities that constitute the Chiari-2 complex. Now, some of those involve displacement of the hindbrain, the lower tonsils and so forth, but also there's a number of factors of Chiari-2 that reflect an intrinsic dysplasia of the entire brain and central nervous system. And whilst prenatal surgery may be good for the displacement aspects, we're by no means sure what effect it has on the more dysplastic elements of the Chiari-2 malformation. And also, we know that from even before MOMS, shunt rates for hydrocephalus were gradually reducing over the decades, as also was the need for Chiari-2 decompression surgery. And again, I think many centers around the world are seeing that they are not decompressing as many Chiari-2s as perhaps they were before, even in postnatal cases. What about motor function? Well, again, also when one looks at this systematic review of these later cases, there does appear to still be an advantage to prenatal repair over postnatal repair, though as you can see from the number needed to treat, this correlation not quite as strong as it was for hindbrain herniation and hydrocephalus. And of course, we all know that a proportion of children who are mobile in infancy and childhood may not necessarily maintain that mobility into adolescence and beyond. And also, this is some work that was published by Sergio reporting his results. Yes, in about 1/3 to 2/3 of cases, motor function is about 2 or more levels better than would be expected from anatomical level. But of course, the corollary of that is that in up to 1/3 of cases, actually there's no difference or perhaps even worse than expected. So it's not exactly a slam dunk in terms of motor function. What about bladder function? And clearly our urology colleagues and us also are very interested to see what the effects will be on bladder function. And already there has been some work looking at this, but the results have been rather contradictory. Some saying it doesn't improve urinary function, some saying that there is an improvement. If we look specifically at the MOMS data, they reported their urological outcomes back in 2015 and found actually that in the initial cohort, there wasn't any significant difference in intermittent catheterization, but there were some other objective urological changes. Interestingly, however, in last year's publication of the same cohort, looking at them at school age, they then find actually that there was indeed a significantly reduced rate of intermittent catheterization and a higher rate of volitional voiding. Now, of course, one of the arguments of prenatal surgery is the risk of prematurity. And again, when one looks to subsequent studies, there is unquestionably a higher rate of prematurity in infants that have prenatal repair. But in terms of actually what the impact is this, as part of this systematic review and meta-analysis, one of the inclusion criteria was that they were all assessed according to standardized neurodevelopmental outcomes. And when you can see here that actually, even though there is a significant degree of prematurity, that doesn't seem to be reflected in subsequently worsening neurodevelopmental outcomes. So these modest degrees of prematurity do not necessarily seem to have a major impact in these larger cohorts as a whole. What about the open versus the fetoscopic debate? And as I said, Frank's going to talk about this in more detail. I think it is important, though, just to make a couple of points. And that's firstly, that the open technique is reasonably standardized. And that was the one that was used in the MOMS trial. The fetoscopic work, a number of different variations on the theme of fetoscopic surgery have been tried. And Bill, as you know, and his group have done some excellent research looking at this. But at the moment, it's not appropriate to simply translate the results of the MOMS trial to those of the fetoscopic. And it's important that we look at those outcomes in detail going forward. But I think certainly when one looks at the fetoscopic data, unquestionably, it appears to be associated with better uterine health in the longer term. But this is offset by other problems. You know, there is an increased risk of premature rupture of membranes in the fetoscopic group, preterm birth, and problems of at the fetal repair site post-delivery. I think in a very nice means of trying to, if you like, hybridize the advantages of each. Fabio Peralta's group, who I mentioned already, has been doing the surgery through a mini hysterotomy of reducing the hysterotomy size down to 3 centimeters and producing very good outcomes in terms of the hysterotomy site whilst maintaining the good functional outcomes for the fetus. So I guess to summarize, where are we? I think from the evidence that continues to be accrued, much of what is said in MOMS has been sustained. Shunt placement rates do seem to be lower. Hindbrain herniation also seems to be lower. So I think these can be regarded as clear benefits. Where one's looking at motor function and sphincter function, I think the benefits are perhaps a little more marginal. But can we explain this apparent dichotomy or these changes? And I think when one thinks about what is actually happening in fetal surgery, there are perhaps two components to it. There's one that's a simple hydrodynamic feature of stopping CSF leaking out of the baby's back, and that we can achieve very well through both open and now fetoscopic techniques. And so that will actually improve some of the parameters for the fetus. But in terms of the neuroprotective aspects, do we really untether the spinal cord either in prenatal or postnatal by open surgery or fetoscopic? And probably not. And as you'll remember from the MOMS trial, there was an 8% risk of clinical retethering in the treatment group compared to 1% in the postnatal group. There are other later problems that I think are becoming increasingly recognized, and that's the problem of inclusion cysts. And even before in the pre-MOMS trial, this was on radiological studies as high as a quarter of the patients showing radiological evidence of inclusion cysts or found at subsequent tethering surgery. So I guess to come back to the original question, controversies and controversies around prenatal surgery, I think there is now, reasonable consensus that prenatal surgery has consistently been shown to be associated with reduced rates of shunt placement and improved hindbrain herniation, with the caveats that I mentioned earlier. But I think certainly, yeah, we still recognize, and I think the maternal medicine people are highly concentrating on this, that standard surgery does have a risk to the uterus, and clearly that needs focus in the future. On a more controversial note, what really are going to be the late motor and sphincter benefits going into teenage years and beyond? Can the fetoscopic techniques replicate the open and maintain the good outcomes from fetal surgery whilst improving the outcomes for the mother, yet not compromising outcomes for the fetus? And is there an acceptable neurosurgical burden going longer term? Yeah, should we be worried about the risk of retethering, dermoid inclusion, and so forth? I think in terms of going forward, I think the directions in travel, I think that people are trying to push the intervention lower for the reasons I explained earlier. And I think neuroprotection, hydrocephalus rates may be improved by even earlier surgery than we're doing at the moment. Can the minimization continue? And I think, as I say, the work by Fabio looking at mini hysterotomy, I think is an excellent compromise there. And we've started using that technique through across Leuven and London. But inevitably, it's essential that going forward, audit, transparency, governance, and risk optimization for the mother and the fetus need to be high on the list. And I think, as Michel pointed out in his recent Titans debate, neurosurgical involvement is essential, because it's actually us that often recognize that issues like this, saccular limited dorsal myeloschisis, is a very different prospect to myelomeningocele, and that differentiation is essential. So I hope that's made some sort of comments to stimulate some of the talk, or to fuel some of the talks going forward. Thank you once again, Ab and Francesco, for inviting me. And if I could just finish by giving a special thanks to some of the colleagues who've helped enormously support me in developing and trying to learn fetal surgery, particularly Jan and Frank in Leuven, but also colleagues from around the world who've invited me into their operating theatres, shared with me their technical experience. That is truly appreciated, I assure you. And thanks once again, folks. Bye-bye for now.
Thank you very much, Dominic. Fantastic talk, and thank you for staying on time with that. Perfect. One of the questions I had was about, your talk was about what life is like after MOMS, and you presented the systematic review. But one of the issues with this, I think, and I want to hear your comments about the experience of individual surgeons and teams, and how that relates to outcomes. And in particular, with that systematic review, the teams that were involved in that, how experienced were they, and how translatable is that to many of the centers out there doing this procedure now?
Yeah, I think it's a good quick question, Ab, and one that I don't think I can specifically answer. But I think you are asking a question that I think is a source of concern for many people around the world. I think there is a tendency now that because this is these results are out there in a randomized trial, everybody wants to set up a center. And of course, as with everything else we do in pediatric neurosurgery, it is difficult to deny there's a relationship between volumes and outcomes. I think in that systematic review, there were two big studies. One was the late follow-up from MOMS, so that was good quality data from a randomized controlled trial. The other one was a case-controlled, a large and well-controlled conducted series from Poland, where they've got big experience. And certainly now, I think, where I've been down to visit the various colleagues in Brazil, who again have got an excellent team-based approach. I think one of the caveats, I think, is though that, as Michelle pointed out in the Titans debate, I think it is very important that neurosurgeons remain intrinsic in this subject and taking it forward. But as I say, actually at the moment, could I specifically give you numbers on the volume outcome correlation? I can't, but I think definitely something worth looking for the future.